Good day, friends, and a warm welcome to 4D, Detailed Discussion and Dialogue in Diabetes, in Indian Diabetes. This is season 3.0 and it's episode number 4. Now, 4 is a very important number. It's a very powerful number as well. 4 seasons, north, east, southwest. 4 directions, summer, winter, autumn and spring. And you see already what's happening when the number 4 is involved, then things happen to our cognition. We begin to think out of the box and we learn new things. And that is the beauty of 4D. When we connect with each other, we learn new things. We learn new perspectives about our work as doctors. This is episode 4, like we said, of season 3.0. And we'll talk about heart failure, chronic kidney disease, and diabetes, where these diseases intersect and where the guidelines converge. We'll talk about how to treat these conditions together as teamwork using strong, powerful, and effective drugs. And we'll see how we can use teamwork or how we can use these drugs to give us an example of teamwork. Speaking of teamwork, let's welcome 3 wonderful doctors who work as a team. They are all from the city of Chennai. A warm welcome to Dr. Ashwini Latha. Warm welcome, Dr. Latha, madam.
Hi, sir.
How are you? Dr. Latha is an experienced interventional cardiologist, skilled in all the various coronary interventions, a graduate from Frontier Lifeline Hospital. She has served at leading hospitals including Meridian, Reela, and MS and JP. And her forte is patient-centered, person-centered cardiac care. Thank you, ma'am, for being with us.
Thank you, sir. Thanks for nice introduction.
An equally important member of the team is Dr. Adeline Reena Ashirvadam, one of India's most popular endocrinologists. She is professor of endocrinology at Sri Ramachandra Medical College in Chennai, and she is famous across the country for her oratorial skills and also for her person-centered care. Warm welcome, Dr. Reena.
Thank you, sir.
From Dr. Reena and her family, I have learned the art of using the Thirukural to inform person-centered care, to inform diabetes and endocrine care. And we'll request Dr. Reena madam to speak about that, what she has learned from the Thirukural. And because the entire country is watching, perhaps she'd like to talk about what this epic is, what this famous book is, to make us all conversant with the text. But we'd also like to welcome a very handsome person, Dr. Ram Prabhakar. He's a nephrologist. He's a very shy nephrologist, as you can see from his smile. There it comes. He is director and senior consultant in nephrology at SIMS Hospital, Chennai, and a gold medalist, a recipient of multiple awards. He works not only in general nephrology, but also in transplant nephrology. Warm welcome, sir.
Thank you, sir.
We were speaking about teamwork, Dr. Latha, and we were speaking about person-centered care. So when we use the word heart failure as a diagnosis, heart failure for you now, is it a cardiac disease or is it a multi-systemic disease, madam?
Sir, it's a multi-systemic, sir. Because a cardiac patient who comes with a heart failure also will have a CKD, he might be diabetic, and diabetes and all these comorbidities will be the other way causative factors of the heart failure. So I would say that the heart failure is not only the cardiac, but it's a multifactorial.
So it is multifactorial, which means multiple causes, multiple contributors.
Yes, sir.
Sometimes we get confused also. So we have multiple causes, we have multiple contributors, and we have audience from across the country. We are all aware of most of them. Most of us are aware of most of them. But let's talk about confounding factors. Dr. Ram, here in Haryana, where I work, our doctors are very fond, our village doctors. So when the patient comes with fever, acute febrile illness, they will say, you have got malaria. If the patient responds in 5 days, fine. Otherwise, they will say, what happened? The malaria got converted to typhoid. Now let me give you treatment for typhoid. So similarly, from a metabolic perspective, let's talk about acute kidney injury, chronic kidney disease, and heart failure. Is it possible in practice that heart failure gets converted to acute kidney injury or vice versa? Can they occur simultaneously? Can they occur sequentially? And have you ever had to fall back upon that? The question is, how do they confound each other? And then how do we clear that confusion? How do we diagnose what is the primary cause?
So it's a very tough question to answer. Rather, it is quite lengthy also. So I would say the heart and kidney function is quite interrelated. There were times when we all graduated, I think we hardly come across the consultation or discussion with our own cardiology colleagues. Now it has become a day-to-day affair, and that shows that the organ functions are so interrelated. So the diseases of one another can affect the another one in multiple ways. So what starts from one organ ultimately will lead on to the dysfunction in the other organ. So that is how the connection goes. So even if you look at the spectrum of cardiorenal syndromes, it starts from even acute cardiac to acute renal to towards the end to the stage 5, class 5 or stage 5 or type 5, where we get both cardiac as well as renal injury, chronic cardiorenal syndrome. So what starts at one can lead on to another, definitely. The prevalence depends on the stage in which you are identified. For example, if you look at simple chronic kidney disease per se, the prevalence of heart failure goes up to 70% as you reach stage 5 CKD and people are on dialysis. But this may be around, say, 20% when they have in the early CKD around stage 3 or 4. Again, it depends on the native disease, whether they have general fluid overload, glomerular disease, or they have interstitial disease where they have no problems with volume. So many factors play a role.
Thanks. So Dr. Ram spoke about cardiorenal syndromes, and we have 5, 1, 2, 3, 4, 5. But Dr. Reena, is it the commonest might be 5, where you have simultaneous instead of sequential presentation, and then the commonest cause must be diabetes. Is this true for your practice? You work in a tertiary hospital. How frequently, madam, do you see diabetes? That's one question. Then how frequently do you see diabetes causing cardiac disease, renal disease, especially heart failure?
Yeah. So as already mentioned, I think the prevalence of diabetes is increasing steadily and steeply. So we get to see more and more patients with diabetes, especially the young onset diabetes that is happening currently. And when we look at numbers, the numbers are relatively alarming, right from the global data as well as from the Indian data. And because I work in a tertiary center, probably there might be a bias because I get to see more and more diabetes-related complications. That would definitely be there. But even then, I personally feel that the prevalence of diabetes has increased drastically, and that is the reason why we are also seeing more and more complications. So the macrovascular complications like cardiovascular disease, the stroke, peripheral arterial disease are also quite significantly high. But most often we get to see the microvascular complications, especially nephropathy, much more common in our patients with diabetes than even retinopathy. So I think there is probably some regional prevalence for diabetes-related complication, or it could also be the reason why probably we are not screening adequate enoughly for the retinopathy and other complications, that patients come to us with a CKD, and that is the reason why we see more CKD also.
So Dr. Lata, madam, like Dr. Reena has said, complications are increasing. Now, when I was a student, I still remember in my MD exam, there was a spotter, and the spotter was a person with a CABG scar. So, I mean, that was how rare it was. If someone were to tell you this, and this is actually true for me, I got that as a spotter. So, what's the situation now? How many patients have got, in your practice, how many patients have got an angiography done? How many have got a ballooning or a PTCA done? How many have got open heart surgery done? And would you be able to imagine a situation where these were spotters for us in MD medicine?
Yes, sir. Sir, actually, the incidence of CAD is increasing, sir. And previously, it was in elderly group. Like now, even the youngsters, even the younger patient of mine, 24, I have seen. So, which is quite alarming. And unfortunately, all these youngsters are having diabetes with very bad metabolism, and they are obese, and it's not like they are very healthy, fit, and they have come with the CAD. They have all these other problems also. They have either other all the risk factors, or mostly they are having diabetes. Most of the people are with high lipid levels and or systemic hypertension. And among these, like if I do around 150 angiograms per month, among them at least my conversion to angioplasty is around 15 to 18 cases, which is quite high. All of them are having significant disease, and most of them are coming with an acute ACS event. And nowadays, with the availability of a lot of gadgets, what we have, OCT and atherectomy devices, and hardly sending for the CABG, because all these youngsters and all are not like really fit until they have like very bad uncontrolled sugars and very bad disease, three-vessel disease. So the CABGs are also happening. Maybe like I could say that I'm giving like around 2 CABGs per month if they're really unfit for the interventions.
So now we can't put CABG as spotter in MD exam. Na? Even the student would laugh at us if we were to do that.
Because of a lot of interventions happening, and of course it's correct, sir. And all this robotic surgeries are also been there, where the midline scar is not seen. It's like minimal thoracotomy. People have some fantasy to go for that to avoid the sternal injury and all.
And Dr. Ram, now that we are speaking about vascular health, cardiovascular health, vascular health is important from a nephro perspective as well. So when we are screening somebody, maybe with CKD stage 4, and we talk about the fact that you need a fistula, you need to get access for dialysis. Sir, what are some of the challenges that you face? What does the community say to you? How do you navigate these challenges? Any difficult cases that have come to your mind? And if we were to speak about vascular hygiene, what would you suggest for all of us? I have a patient with CKD stage 3B, stage 4. How can I ensure vascular hygiene so that it becomes easier for the patient and for the treating nephrologist later on?
So it's as such, our specialty itself is a very challenging field. The moment they hear the word dialysis, people will run away. That's what happens many times. Whenever we say that this is not a disease which is curable, it's only we can reduce the rate of progression. Again, people definitely go for all sorts of options. They try all sorts of medicine. They at least go through 2-3 nephrologists before they come to terms with this disease. That is the biggest challenge what we are facing. Convincing people that it is a progressive disease. It might go bad, and we have to plan all these depending on the stage of presentation. That is the biggest challenge. The part regarding vascular hygiene, that is a major point, in our population, particularly with obesity, and in women, the quality of veins are very poor. For us, vascular access is the Achilles heel on dialysis. People, with whatever form of renal replacement, the therapy they choose has to undergo an early AV fistula creation, because that once you get a very good access, you can keep them on dialysis quite easily. Because vascular access problems are the biggest problems apart from cardiovascular disease in dialysis patients. So in a way, if we advise people, first is to avoid unnecessary venipuncture, because a lot of people puncture most of the vein. By the time they come to us, there will be no vein without thrombophlebitis or thrombosis. So we always say, at least preserve a non-dominant arm. So usually we have to ask them before right or left-handed, and if it is a non-dominant arm, ask them to preserve that arm at least without venipuncture. Then probably, if suppose some quality of vein is poor, we advise them for some basic AV fistula exercises to develop the vein further. And obviously, we have to look for signs of vascular insufficiency, like forming any digital gangrene or discoloration, ulcers, and so on, before planning an access in that limb. So this is the way, an overview for a generalist, I would say. And though there are some sophisticated tests you can do on the hand before doing AV fistula, but the basic thing still remains these things. And particularly with cardiologist on board, we have to look at the pacemaker leads. So this also has happened in some patients. If you create an AV fistula on a patient who has a subclavian punk lead, then there is a high chance of central vein narrowing there. So this also has happened. So we always ask for these things when you see a patient.
All these are very important factors, and so much that I've learned from you. Thank you so much, especially this aspect about venous enhancement exercises. So this is something that we can advise our patients. And when you do this to your patient, someone with CKD stage 3, 4, 5, as it is, they are irritated with themselves, they are irritated with the entire world and their family, and all that gets projected upon us as physicians. So they also get sick and tired. You are talking about drugs and tests all the time, drugs and diagnostics. So you can tell them simple exercises which make them feel happy. And you convey that I am here with you, I am trying to promote your health. Dr. Reena ma'am, Dr. Ram spoke about vascular hygiene. But what does the term glycemic hygiene mean to us? Somebody coming in with diabetes, somebody coming with pre-diabetes, somebody coming in with heart failure or CKD, even if they are normoglycemic, how would we inculcate the practice of glycemic hygiene in them from a pharmacological as well as non-pharmacological perspective?
I think the non-pharmacological interventions still have a very significant role to play, regardless of whether they fall in the pre-diabetes category or diabetes without complications, or it could be diabetes with complications as well. So I think emphasizing on a good physical activity, whatever they could tolerate or whatever is allowed for their effort tolerance. The second would be to watch out on their diet to improve their protein, more of fiber, less of carbs and fat. And again, in promoting a good sleep hygiene, very, very important. Many times, a lot of times it is underestimated. All these things also have to be put in place before we really up-titrate on the pharmacological management. When it comes to glycemic control, the way we were looking at an ideal target HbA1c has changed. No more do we look at 6.5 or 7% for everyone with diabetes. We do fix a target for the given individual whom we are actually encountering for a consult. So if the patient is younger, if the diabetes is for a shorter duration, if the risk of hypoglycemia is lesser, we would be probably looking at achieving a better control as low as an A1C of 6.5 without hypoglycemia. Whereas once the complications set in, then probably our threshold for an intensive glucose control goes a bit more higher. So we would try to achieve as close to 7 as possible without allowing for an episode of hypoglycemia. So I think the way we look at the glycemic control and the way we are trying to achieve the glycemic target has varied, and that will differ depending on the treating population.
Dr. Lata ma'am, we are on this concept of hygiene now. A person with heart failure, we are aware that just like we have diabetes nursing, now heart failure nursing is evolving as a separate specialty. So ma'am, someone who is at high risk of heart failure, somebody who has already been hospitalized for heart failure, what are the hygiene measures that we can tell to the patient and to their family? Maybe in terms of physical activity, lifestyle, stress management, spirituality, diet. What are the simple things that we inform them so that we can reduce the risk of hospitalization in future?
Yes, sir, it's a very relevant point. Actually, patient with a heart failure, especially with the reduced ejection fraction. So we need to give them a lot of tips and to how to identify the early signs of heart failure so that the next hospitalization can be avoided. So the simple tip, usually I will ask them to go for a weight monitoring measurement every day. So as soon as they get up and fresh up, and I will ask them to go for a weight measurement. So, and I will ask them to note it down. If the patient is having a severe LV dysfunction, to note it down and also check the vitals every day. So as in when there is a water retention, the weight gain of more than 1.5 kilos, I will ask them to come back immediately, because that threshold I have kept of around 1.5 to maximum 2 kilos. Because beyond that, the way patient is getting a weight gain, then that means that he is going for a fluid overload status, which will be next impending heart failure. Apart from that, I will ask them to measure and take the water and to cut down all the fluid diet, and also that only they can concentrate on the fluids, because they are advised to go for a low fluids, which is ideally important for them, because we can't keep on giving higher diuretics so that we have a problem with hypokalemia and other issues, also hypotension, so that the diuretic dose can be at the minimum maintenance level so that the fluid restriction will be. And these patients also have a CKD where the fluid restriction is very mandatory. And apart from that, the salt intake. And the other tip I give them is like not to add any salt while cooking, and just sprinkle over when you are eating, actually. So that's the easiest way to cut down the salt intake. And I feel that this is the best thing to do. And of course, cardiac rehabilitation. The patient is young and coming with a heart failure, even with a preserved LV function. So I would be asking them to join for cardiac rehabilitation program so that we can prevent the further failures and risk factor management also.
You want to bond with the patient, you want to ensure adherence and persistence. These are the things to speak about. The same way Dr. Lata madam is sharing with us, the same way Dr. Ram has shared with me. And so patiently, they are explaining what they are doing in their OPD. Now, I also feel qualified that I can go to Chennai and talk about diet. So that is the feeling I am getting listening to both Dr. Lata and Dr. Prabhakar ma'am. Dr. Reena ma'am, a message for you from one of our senior most diabetologists in the country. So from Madurai, Dr. Arthur sir says that everybody says that Hippocrates said, make food your medicine. Food is your medicine, medicine is food. But what people forget is that Thirukural, so long ago, in his Kurals, in Thiruvalluvar, so long in his Kurals, in Kural 925, 941 and 943, he has talked about the dangers of overeating. So he says, prevent overeating. And then he has talked about the benefits of healthy eating. And he talks not only about the quality, but also the quantity, the balance. He talks about balanced diet so long ago. So, madam, who was Thiruvalluvar? What is this book? And can you share for an all India audience, ma'am, what we learned from Thiruvalluvar?
I think the best part of Thirukural is we have a series of good information, very, very reliable information and relevant information even for the current era. As you rightly said, it was written 1,000 years ago, and we still have it to show the relevance the problems that we face right now. The second important thing is it's very short, it's very brief, so people can remember and understand it better. And even for people who are from the other part of the country and even from all around the world, people look at Thirukural as good information and very catchy, small, brief information. So, as you were already suggesting, there is a Kural saying, Noi Nadi, Noi Mudal Nadi, Aduvanettu Mai Nadi Vaipa Seyal, which means that you diagnose the illness, but don't just stop there. Trace the cause, identify what exactly has gone wrong for that individual, and then treat them and make sure that doesn't occur again. So it's talking about diagnosis, treatment, prevention also. Yeah. So that way, I think that is the same mantra that we talk about. Even that's what we are discussing in this integrated cardiorenal metabolic care that we are going to look at in patients with type 2 diabetes. So treating diabetes, I think we need to go back to the roots, not just prescribe medications, as you rightly said, and probably look at the patient as a whole and try to prevent the risk factors that is contributing to all this entire spectrum of CAM.
That is so beautiful, madam. Dr. Lata, do you think Thiruvalluvar was a cardiologist at heart? Does this shloka, does this Kural make sense to you? Do you think
Yes, yes.
It should be? Yeah, ma'am. Any examples from your practice? Maybe you made an error of judgment, you did not follow Thiruvalluvar, or maybe some example where you actually followed him and you got good benefits, ma'am. Anything that is coming to your mind from your OPD, ma'am?
Actually, of course, as a complete approach to patient is really going to be beneficial to the patient, and outcomes is going to be very good, sir. Rather than just looking at the heart and forgetting the kidney and other things, is not a good idea. We have to look it as a whole and then treat the patient.
And Dr. Ram, Dr. Reena shared this Kural, and it is in Tamil. I am aware that we have got a classic Tamil and a street level kind of Tamil. So, if you were to share this with your patients, what would happen to the compliance, the adherence, the persistence? Would it make sense for the average patient who enters your clinic? How do you think you can use this Kural?
So yeah, it is for us, for Tamils, Thirukural is a very, very important book. I think all of us at our generation read in schools. I don't know about the Gen Z now. I'm not sure how many of them are very familiar.
They do read, sir. Yeah, they do read.
Dr. Reena has read.
No, I read it for my daughter now, so they do read, yeah.
Yeah, even we do team there, sir.
So actually, to be frank, when we read as students, we were not actually, it was not very impressive because that was actually forced on our throat. But now if you ask me, as you said, have been fascinated by the contents of them now. I think, as she said, there are a lot of times we start our lectures quoting Tirukural in some form or other, and we are learning every day in from Tirukural. That's the way I look at it. There are many Kurals we can. Since you are asking impromptu, nothing comes to my mind. But if you ask me to talk about Tirukural, I can also speak for an hour.
We would love to listen to you. Dr. Reena ma'am, one more suggestion coming from Dr. Arthur sir. Dr. Arthur says that he has used Kural 950, verse 950 so many times in his practice, like Dr. Ram and Dr. Lata just said. So in 950, Thiruvalluvar says that a successful treatment is based upon 4 pillars, 4 key elements. That is the patient, the physician, the product or the drug. So P for patient or person, P for physician, P for product, that is medicine, and P for the paramedical staff, the attendant, the person who is preparing the medicine. All 4 have to be equally good. He says that today, when we use the English phrase person-centered care, we think it is a modern innovation. But again, Thiruvalluvar taught this to us so many thousands of years ago. So, ma'am, in the diabetes practice and in heart failure also in CKD, what is the role and responsibility of the patient? And can we use verse 950 to motivate our patients for better self-care, better self-management?
I think absolutely, sir. Because as you said, as Dr. Ram sir also mentioned, I think many times it summarizes what we actually want to convey in the entire lecture. So I think Tirukural still has relevance, as I already mentioned. And especially with regards to the 4 components that you talked about, I think that is another way of probably explaining the integrated clinical care that we are trying to offer to our patients with type 2 diabetes, where you have an endocrinologist or diabetologist, nephrologist, cardiologist, and more importantly, I will also emphasize the importance of paramedical staff, be it a clinical nutritionist or a physiotherapist or a psychotherapist. Every single individual who is a part of this team have a role to play, and that's going to give a holistic care to our patients, and that is what is going to take them through a long-term diabetes, because we know that it's all chronic disease and we can't make and create magics with just a medication, just initiating them on insulin. So I think it all has to come together and everybody has a role to play.
We have a comment, ma'am, for you. This comment is coming from Professor Sriram Mahadevan and Dr. Vijay Bhaskar Reddy, who say that actually teamwork is important, and that is how endocrinology, nephrology, cardiology are growing up. So there is a comment also saying thank you for being a great team member of your hospital. This is from Dr. Mahadevan.
Thank you, sir.
Dr. Lata madam, we have spoken so much about hygiene and we have spoken about philosophy and physiology, but the patient will finally come and say, ma'am, what about the medicines? So let us focus on SGLT2 inhibitors. Are you using any medicines in neuropathy where you can tell the patient that this medicine is a teamwork kind of a medicine? This medicine will offer hygiene. It will offer you metabolic hygiene, glycemic hygiene, renal hygiene, and also cardiac hygiene. It will do all 4 things put together, since that is the power of 4. It will help you promote health, prevent disease, and also manage disease. It will help prevent hospitalization. It will help improve longevity. It will improve the quantum and quality of your life. So many things put together, ma'am. Can you put that all in one pill for the patient? And how do you explain SGLT2 inhibitor use?
Yeah, actually, you told everything about SGLT inhibitors. Actually, and it's actually very easy to initiate to the patient. When we say the benefits of the pill, actually, the patient would like to take it. So we can say that, see, by taking this, you will have a better glycemic control. Your CKD progression will be halted, and also you will have a heart failure management. It's very good, and there are chances of quality of improvement in life, and the NIHA class will improve, and prevention of heart failure and hospitalization, reducing the mortality. So once we explain it as what you told, patient will agree to take. And of course, it's very patient-friendly medicine, so it's easily available and cost is effective, so that all the patients usually will like to take it. Very few have some side effects, but it's manageable.
So initially, ma'am, we were speaking about the various causes, the various contributors, and the various confounders of heart failure. Ma'am, all these multiple things, do you feel that SGLT2 inhibitor like dapagliflozin will be able to cover all of them and will be able to provide curative support irrespective of what the confounders and causes contributors are?
Yes, sir. Yes, sir. It will cover. Even sometimes, even if a patient is non-diabetic, we will tend to give them because it has the other benefits. Like not only the diabetic patient is going to benefit from heart failure, even non-diabetic patient is because of osmotic diabetics and other benefits of the drug actually, and so it's going to be beneficial.
So, ma'am, if I have someone with preserved ejection fraction or reduced ejection fraction or moderately reduced, can I use DAPA in all these patients?
Yes, sir. You can use it.
So that is also something very comforting then, that you don't need to worry too much. And supposing I'm in general practice, the echo has not been done yet, the NT-proBNP has not been done, but I see that the patient is at high risk, I can start DAPA from a cardiac perspective as well.
Yes, sir. We can start, sir. At risk of diabetes, it is at risk of heart failure, it is a good drug to start, sir.
Dr. Prabhakar, comment coming your way from New Delhi. Professor Saurabh Sharma says he is very much impressed by your description of vascular hygiene. So he says to add to that vascular hygiene, can we use dapagliflozin in persons with chronic kidney disease? And would you have a lower threshold for EGFR for when to discontinue, when to be more cautious?
So, see, the use of SGLT2 inhibitors is increasing in every field. In nephrology is not an exception. We use for both diabetic as well as non-diabetic kidney disease. We have more than enough evidence to substantiate this argument. But the problem is the cutoff GFR. Many times we receive patients with very advanced CKD where we may not be able to use it. If you look at strict FDA regulations, I would say dapagliflozin, as per the DAPA CKD study, the lowest GFR enroll is 25. As per the EMPA kidney study, the 20 is the eGFR. So, if you ask as a KDIGO guideline as such, the guideline says you should not use it for below 20 eGFR. That is as of today. But if you get studies further and further, and there are studies which are going on even on dialysis population, so they may get revised downwards. But what we do is, once we start the drug, if there is a cardiac indication, we continue this drug even though the patients undergo dialysis. So that is the way we use it. We don't start anybody newly once the eGFR is less than 20. But if somebody started because of heart failure or other indication, we tend to continue it. The proportion is definitely much lesser than the other fields, but definitely it has a big role in diabetic kidney disease with heart failure. Even in non-diabetic kidney disease, there where the magic happens. But if you look at a disease like IgA nephropathy, so in a disease like IgA nephropathy, the largest evidence or the largest trial that is treated is SGLT2 inhibitors. We have n number of studies involving steroids, other cytotoxics. But if you look at the patient enrollment per study, SGLT2 inhibitors are the classes which have the highest enrollment. Both the DAPA CKD and EMPA kidney had substantial proportion of IgA nephropathy patients. So for IgA nephropathy, it has become almost like a standard of care nowadays. So the evidence is evolving as we get more and more studies. Definitely the usage in both diabetic as well as in non-diabetic kidney disease is going up tremendously.
What we can explain to our colleagues who are not actively involved in nephrology is that above eGFR 25-30, you will have glycemic benefit and also metabolic benefit. But even as the eGFR goes below that, as long as there is no other contraindication, patient will continue to get metabolic, especially cardiometabolic benefit. So that is what Dr. Lata and Dr. Prabhakar sir are saying, that you continue the drug even if you feel there is going to be no glycemic advantage. The heart musculature, the overall endothelial function, that will continue to improve. Sir, like Dr. Lata madam mentioned, that irrespective of eGFR, irrespective of ejection fraction, we can use dapagliflozin. So is this true that irrespective of albuminuria, we can use? Can I use the drug in albuminuric and also in non-albuminuric kidney disease?
So definitely yes, even in non-albuminuric CKD, if you look at the subset data from both DAPA as well as the EMPA kidney study, even in the benefit remains even in normoalbuminuric subgroup. So we don't go by albuminuria alone in deciding whether these patients on SGLT2 inhibitors. Yes, see, it is beneficial both in diabetic as well as non-diabetic CKD. Similarly, albumuric versus non-albumuric CKD.
Dr. Reena, madam, from a diabetes perspective, so what is the spectrum of usage and any contraindications, caveats, any concerns?
I think with the way we have understood this molecule over the last decade, the more and more indications that we get for the benefit of this molecule, I don't see a reason why we should not initiate right at the first visit of patients, unless you have individuals who have significant hyperosmolar symptoms, or when there is a presentation with DKA, or when there is a significant risk of pyelonephritis or a recurrent UTI, there's some structural problem. So when you are sure that there are no absolute contraindications for this molecule, I think it can be used even as an anti-diabetic agent, as the first line drug along with metformin. That is number one. Number two, now we also have a lot of evidence right from the EASD, EAC recommendation that it can be used even before metformin if the cardiovascular risk is much higher than what we generally have. So that way, I think, though it initially kickstarted as an anti-diabetic molecule primarily, then it went into the portfolio of the cardiologist, followed by nephrologist. Now we have so much of data coming out from the MASLD as well. So I think it has a pleiotropic benefits. So we can definitely use this molecule, provided we are sure that there are no absolute contraindication in that given individual.
One question, ma'am. This is coming from Dr. Ramya Rajan from Vellore and Dr. Lakshmi Nagendra from Mysore. They are asking, what about the impact on bone health? Earlier, there was some suggestion that it can impact osteoporosis or bone health. Is that still true? What does current evidence say?
I think that observation came from with the canagliflozin, but canagliflozin is no more available now, and we don't have any such reports with both empagliflozin as well as dapagliflozin. Basically, they do not actually promote osteoporosis, unlike what we actually see with the pioglitazone group of drugs. But however, obviously, when we use it in these kind of high-risk patients who are already at risk of osteoporosis, we have to treat the bone health, because the benefits that we have with this molecule completely outweighs the risk, if at all it has. But as of now, there is no proven association or a strong causation of osteoporosis with SGLT2 inhibitors.
Thank you. Dr. Lata, madam, one other class of drugs that we use in India for diabetes is sitagliptin. And the TCOS trial, this was one of the earliest trials, CVOTs, that showed that sitagliptin is safe from a cardiac perspective. So, ma'am, supposing a patient comes to you, patient is on dapagliflozin and sitagliptin FDC, glucose control is fairly okay. Would you continue? Would you discontinue? How do you address the use of such drugs from a cardiac perspective?
Sir, actually, gliptins are good enough. So, if the patient is already on combination of DAPA with gliptin, I would like to continue, sir. And in fact, beyond the SGLT inhibitors, some other medicine to start, I would like to start the gliptin, because it hasn't shown the complete benefit, but it is not harmless. It is not harmful. So I would like that to add it, sir, because it has lesser incidence of hypoglycemia. Patient can tolerate very well, and not much of weight gain. And I would like to continue, sir.
That is one very strong advantage, ma'am, that you have mentioned, that there is less risk of hypoglycemia with sitagliptin. Dr. Ram, from a renal perspective, how important is hypoglycemia for you, and how do you view sitagliptin? How do you adjust the doses?
So, with only using fixed dose combination in nephrology is tough with any molecule for that matter, because adjusting them individually will be a problem based on GFR. Particularly with sitagliptin, we need to reduce the dose when the GFR is less than 30. So that's the only issue we face. Otherwise, I don't think we have any big issues with the molecule per se. As such, we can all very well combine these drugs together in kidney disease also.
And Dr. Reena, there's another issue sometimes that people say that with SGLT2 inhibitors, we have increased risk of genital tract infection. If we were to add sitagliptin as an FDC or otherwise, what does that do to the risk of infections with SGLT2 inhibitors?
The first risk factor for UTI or genital tract infection is hyperglycemia, uncontrolled diabetes. So when we are able to bring these two molecules in combination as FDC, and we are able to see a higher A1C reduction, which is often associated with an FDC, say from 1.5% to 1.8%, that's going to definitely bring down the risk of any infection for that matter, especially the UTI, which all our diabetic patients are very prone to. Number two, there have been suggestions with even a systematic review and meta-analysis has been done in patients in whom they looked at who were only on SGLT2 inhibitors, only on sitagliptin, and those who were on combination of sita and SGLT2 inhibitors. So what they're actually shown is the risk of UTI and genital tract infections are much lesser when the FDC of sita and SGLT2 inhibitors were used compared to SGLT2 inhibitors alone. Now, there are several hypotheses as to what is the mechanism that is contributing to the lower risk. For example, there's been a hypothesis saying that the DPP4 enzyme inhibition, even in the microorganisms, probably would destroy the organisms, and probably that is the reason why the risk is less. So we really do not know the exact reason why the prevalence is lesser, but we do have some data to show that FDC of sita and SGLT2 inhibitors are associated with lesser incidence of UTI and genital tract infections.
Dr. Lata, madam, there is a comment from Dr. Jaikrit Bhutani. He is a cardiologist in Jaipur. So the same comment, maybe it's a comment actually and a question. So the same for all three of us. His comment is, ma'am, your topic was heart failure, CKD and diabetes. Where do the guidelines converge? And you have talked about everything under the sun, including Thirukural, but you have not talked about where the guidelines converge. So, ma'am, in a few sentences, could you please answer this question?
Sir, as per the recent heart failure guidelines treatment, it is one of the pillar. SGL2 inhibitor is one of the treatment pillar out of 4 heart failure pillars of treatment. So, along with the beta blockers, MRAs, and ARNIs, SGL2 inhibitors is indicated, sir. As soon as we find the patient at risk of heart failure, and definitely in a patient with a heart failure, we have to start SGL2 inhibitors so that the prevention will be better. And of course, along with that, the patient other risk factor control can also be easily managed when we initiate this heart failure. So, and to see, like, we have to see the patient as a whole. So once we are preventing heart failure, that means we also should be targeting that the molecule should be useful benefit for the patient in terms of diabetes control also, and this molecule should be avoiding the other kidney progression also. So considering all these things, the SGL inhibitor is very good because it inhibits the RAS mechanism, and also it further avoids the endothelial dysfunction and prevents the fibrosis. So overall, the SGLT2 inhibitors is good in treating all these diseases together.
So that is convergence. Dr. Ram, same question to you. And Dr. Jaikrit is joined by a nephrologist, Dr. Sahu, from Bhillai and Chhattisgarh. So the question is, where do the guidelines converge regarding use of dapagliflozin and sitagliptin?
So regarding heart failure management, if you are asking in presence of CKD, there is a very subtle difference only, more or less the same, except that you should be aware of certain molecules, and the awareness about hyperkalemia should be there. So generally, the foundational therapy remains the same. It is combining of SGLT2 inhibitors, ARNIs, beta blockers, and MRAs. So these 4 are the basic foundational pillars. Now slowly GLP-1 analogs are coming, and the other group of drugs are also joining, like soluble guanyl cyclase inhibitors and so on. So the important things for nephrology practice is the evidence is there. For example, in MRA group, we should be aware that spironolactone as of now should not be used below the eGFR of 45. It's only recommended above the eGFR of 45. And there is emerging data on non-steroidal MRAs nowadays, so that can be probably substituted, but this also cannot be used below eGFR of 25. That's the number we have now. So that is the subgroup. Beta blockers, we don't have an issue. SGLT2 inhibitors, we have talked enough. About ARNI is also the same risk of hyperkalemia is there. So although there is no recommendation, the starting dose should be less when you have eGFR of less than 30, then slowly uptitrate monitoring the potassium. So the molecules more or less remains the same, but you should know when to start and when to discontinue. That is a subtle difference in the guidelines in CKD patients.
Dr. Reena madam, last question for you, and this comes from Dr. Tejal Latia. She is from Mumbai and all her friends. They say that Dr. Lata madam and Dr. Ram sir have already explained how the guidelines converge from a cardiac and from a renal perspective. But we would like to converge in Chennai next year because that is where all good things seem to come from. Chennai is not only the diabetes capital, it is the diabetes care capital, the metabolic care capital of the country. So, ma'am, is there any opportunity where we can come to Chennai next year to converge as physicians and metabolic physicians, and where you may be able to teach us more about the Thirukural and how we can apply it to our practice? That is the question for you, ma'am, from Mumbai and the rest of the country.
Yes, sir. Absolutely. Please, you're welcome because we have SACON 2026 in Chennai. We would definitely love to host you. Now, looking at the convergence of the guidelines, I think from an endocrinologist perspective, I'll be looking at an integrated care where, because most of our patients have more than one risk factors and more than one comorbidities. So it's no longer just looking at the glucose. A proper screening for associated comorbidities is very essential, and to give them an integrated care with multidisciplinary team in place makes it a lot more different. The second thing is addressing at the risk factor stage again becomes very important because we don't want the disease to progress and then try to find solutions. So addressing risk factors, at least checking a blood pressure, checking a urine microalbumin, looking at the fundus, I think that's going to make a lot of difference with regards to bringing down the morbidity and mortality of these patients. And the third important thing is to look at organ protection. So using drugs that can modify the disease would be more preferable compared to drugs that are just going to treat the disease. So that way, I think choosing drugs like, as already sir pointed out, SGLT2 inhibitors, GLP-1 receptor agonists are definitely going to make a lot of difference with regards to the progression of disease and also contribution of complications. Last but not the least is the individual approach. So it's no more a generalized approach or the algorithm that's going to be just a guideline. So we need to look at what best can the patient who is sitting across the table can get with all our inputs from all the specialists, whoever is involved in the care for the patient. And that's how I think that we can definitely improve the outcomes of our patients with type 2 diabetes.
Thank you so much, madam. And all of us who are listening to you, we are so much impressed by Dr. Lata madam, Dr. Ram and Dr. Reena. First of all, we get the confidence and competence. There is competence in all our experts and they are confident. But more important than that, we get the compassion and compathy. When they speak, they actually have that person across the table at the center of all their thought process. And this is true whether you are a cardiologist, a nephrologist, an endocrinologist or a physician. You want to converge, and you want to converge not only with compassion and compathy, not only with competence and confidence, but also with collegiality in such a friendly, in such a familiar way. And if we can incorporate this in our daily conversation, daily communication, I'm sure we will all converge in a state of good health, in a state of health utopia. If we use the latest drugs like SGLT2 inhibitors and their combinations, we will be able to prevent and manage heart failure. We will be able to prevent and manage CKD and also prevent and manage diabetes. And I am very sure that Thiruvalluvar will be very proud of us. On this very happy and very optimistic note, let's do the best possible for our fellow citizens and let us make Thiruvalluvar proud of us. On that, thank you everybody for being with us. Thank you, Lata madam, Dr. Ram, Dr. Reena madam. Thank you so much for being with us.
Thank you, sir.
Thank you.
Thank you.
Thank you.